the reproductive organs or the visceral organs, I want to just talk about two things that make the...
Feel pressured?
And I did not do that. No. I'm telling you honestly, right? Whenever anybody says that, don't believe them. So, there's two things that make this pelvic region difficult. One of them is structural, and it's this. This pelvic canal, which we studied in A&P 1, right, the bony part of the pelvis, forms this canal through which all of the viscera that pass out of the body at the tail end pass, right? Everybody in agreement with that? In other words, the end of the gut tract or the rectum, the urinary exit from the body or the urethra, and in women also the vagina are all going to pass through here. In fact, this is also the birth canal, right? This is where that tight fit happens for the baby being born, with the skull sometimes even having to have those bones kind of ride up and make that cone head kind of look when they come out. And, you know, that's part of the pain of childbirth and all of that. Actually, I think this would be the female pelvis here. So, but either way, that's what we're talking about. And so if that's the outer tube of the body at the tail end, embracing or wrapping around those viscera, we would expect it to be in a cranial caudal orientation, right? And superior, inferior orientation. But if we look at the skeleton, I think these ones are sort of mounted okay, but the skeleton really makes this obvious. Look at the orientation of that pelvic canal. It's actually like this. It's not quite anterior posterior, but it's kind of at an angle like this, right? In fact, it's at the same angle as we would find in any one of our quadrupedal mammalian relatives. And the reason is that from the basically waist down, we still have that same formation or that same orientation. It's just that we get this reverse lumbar curve here that brings the rest of the body upright over the lower limbs, allowing us to be bipedal or to walk around on two legs. But if you take that vertebral column and you put it back into this orientation and it comes off this way, then we would just be like any dog, cat, cow, elephant, you know, whatever, with our head pointing that way, right? And in fact, that's how we're born. If you think about the fetal position or the typical infant, you know, position where they're curled over like this, they have that C-shaped vertebral column, and I can promise you they aren't going to walk, no matter how much their parents want them to, until around a year of age. There's differential growth in the lumbar vertebrae, and they start to get that reverse lumbar curve. And it doesn't happen overnight. It takes a little while. It doesn't always happen at a year. It can happen a little earlier. It can happen much later, like 18 months or 2 years. And even, you know, when they first start walking, they're not quite fully, you know, the curve isn't fully formed yet. So everybody's seen that typical, you know, they're a little bit forward and they do that tippy-toe thing to try and catch up, right, because they're about to follow. So that's what has to happen. So a lot of times parents think, oh, my baby's not walking. And it just, if they don't have that, it doesn't matter how coordinated they are at everything else, they're just not going to be able to walk. So what it means for us, though, is this orientation is kind of weird. We might expect those pelvic visceral organs to be going superior, inferiorly, or up and down, and they're not. They're also not quite going anterior, posterior. They're just like this. And in fact, if you've ever seen, like when you cut open the abdominal cavity or if pelvic surgery is being done through the abdominal cavity, it's almost like this big recess at the back where everything passes through the pelvic organs, all pass through the body. So, you know, we had to kind of adjust our thinking about how those organs are oriented, and a lot of times we just talk about, you know, anterior, posterior here in the pelvic canal and get around it that way. So that's one thing. The other thing is you know, I think kind of is a psychological thing, or a, you know, I don't know where you want to go with it, but I call it the fig leaf factor. Look, and this is going to be something you folks are going to have to face more than me, as principally primary healthcare providers. When I say primary health, I mean when people first go to see somebody, right, or in that non-hospitalized healthcare setting, and often in a hospital as well, but especially in that primary encounter, 90% of the time or more, it's something at the head end or something at the tail end. At the head end, it's all visible, it's what we present to the world, not that often that we're embarrassed to talk about it. At the tail end, it's the part of our body that we only show to our most intimate loved ones, plus our healthcare providers, right? And so we need a language to talk about it. In this class, I promise you, the only language we use is what's the accepted technical anatomical language. And of course, that's great for us. For you folks, sometimes some of that vocabulary is going to either be unknown to the patients or clients you're working with, or it also might sometimes seem vulgar, even though it's not, you know. And so I don't know how you deal with that. I think it comes back to one of those, you know, principles that we've talked about in the course before, which is that if you bring that 100 respect for the full universe of a human being that's in front of you every time, no matter who they are and where they came from, and when they're bringing pelvic and, you know, tail end problems to you, no matter what kind of behavior it might reflect, especially when we start talking about sexual behavior and all of those kinds of things, you know, yours is not the position to be judging those things. Yours is to try and find better quality of life and help this person who is bringing you what is now something that is not only maybe, you know, a serious health care or well-being issue, but something that also involves the part of our bodies that we're not always that comfortable to even be talking about, let alone showing to somebody who, you know, is going to be somewhat of a stranger to us. So I bring that up because I think it's great. It's one of those places where more than anything, when we think about that and we think about how we're going to use the power we gain in this class from learning the names of all of that anatomy, when we're in that kind of setting,